And the next talk is from Dr. Hachad from To Be Precise Health, Multidisciplinary Precision Medicine Programs, a Population-Based Approach. Thanks very much.
Hi, everybody. Thank you for inviting me here today. It's nice to catch up with friends and colleagues after a couple of years of pandemic. I'm very excited here to be here to share with you our experience deploying pharmacogenomic programs in the United States. So, as you can see, I am with a company called To Be Precise, which is an entity, part of a holding company called AccessDX. We operate other molecular diagnostic labs, as well as we have other clinical decision support systems used in healthcare systems and other settings in the United States. So today, my talk is going to focus on the platform itself, its capabilities, and giving you examples of pharmacogenomic programs, focusing on the different pillars that are necessary to deploy these programs and some of the lessons that I have learned over the years. And finally, I'm going to conclude with giving you a view of how PGX can be integrated with other genomic signatures in a patient journey in the oncology space, and I will end up my talk with some conclusions. So our platform is actually a central hub that integrates databases, clinical decision support, and it's aimed to support multiple workflows. These workflows could be within a lab, a diagnostic lab, molecular diagnostic labs, or other types of labs. It can definitely support pharmacogenomic workflows within health systems, within pharmacy systems, and it can also support some specific oncology workflows when multiple types of tests are needed in the treatment of cancer patients. We see this platform as a unified central hub that healthcare practitioners as well as organizations can actually deploy in order to manage multiple types of genomics information. The clients we serve are, as you can see on this map, spread out all the United States. They include health systems, long-term care, small practices, pharmacy systems, closed doors pharmacies, PBM, pharmacy benefit managers, etc. And our platform can be integrated within EMRs. We're going to see in a minute how we do that, and therefore is able to actually take the genomic insight in the clinical workflow for everyday use at the point of care. In this slide, giving our experience, we foresee that a proper deployment of a sustainable pharmacogenomic program requires these key determinants, we call them also pillars. And these pillars, they can each come with required tools and technologies to properly function in order to maximize their efficacy and utility. I will go over each of these pillars and show you examples of what we have done with our technologies to support these different pillars. So first, the genomic hubs. We all recognize today that there are multiple systems that are hungry for genomic data, of course for pharmacogenomic data. Health systems definitely, because they want to provide better care to their patients, whether within acute care or long-term care, as well as municipalities. And we also have within in the United States skilled and nursing facilities that operate within long-term care. As you can see, they're heavy consumers of medications, and therefore they're also interested in deploying pharmacogenomic programs within their facilities. Finally, we recognize that pharmacy systems, they're not genomics native. They were not built to receive genomic data. Yet, some of these pharmacy systems, like PBMs or other closed-doors pharmacies, are interested in getting that information and act upon medications in order to reduce unnecessary prescriptions. This seems as a heterogeneous base, but our experience shows that the users within each of these genomic hubs have similar needs. They all request the genomic information, especially PGX data, to be integrated within their system. And they want that integration to happen when they select the candidate for testing, when they order the test, when they're notified about the result, and they want to have perpetual use integrated within their system of that information. They all ask for results to be communicated to them in a concise and legible format to ensure appropriate use of results. They don't want lengthy academic recommendations like we love and that we would love to provide to them. They want to be equipped with tools to track outcomes of these programs, to ensure that their users are engaged and to ensure return on investments. So the next pillar that we support, of course, as I said, is how can we help institutions to select the candidates, in other words, the relevant recipients. We're not at a point where we are all candidates for a PGX test. Right now, the modalities that are deployed in the United States are either reactive upon the prescription of a medication or preemptive at the time where some specific procedures are ordered, such as in the case of Plavix, for example. Our platform is able to profile millions of patients and stratify cohorts by looking at medication records and prescription records, as well as conditions, in order to provide scores or benefit, whether the test would be of benefit for that patient or not. We can acquire multiple medication records from different repositories that could be in electronic medical records, for example, or in pharmacy records as well, or from a pharmacy benefit manager records. We can analyze these medications and we can keep track of the changes of these medication profile by providing this constant monitoring. We have tools to assign risks and scoring medications, focusing on PGX relevant medications, for example. This is a screenshot of a cohort stratification dashboard that we offer for an organization. And as you can see, what we do is we create specific rules for clinical use cases, and in order for us to inform an organization of what are the opportunities for them to test their patients. You can see that polypharmacy patients are quickly identified, and within the polypharmacy, we can drill down in analyzing the medications that have pharmacogenomic relevance. We can stratify these patients also by subspecialty. This is often very useful to an organization who is interested in launching PGX, but they're not sure about which population within their health system is likely to benefit. We can also drill down and set and deploy other types of scores by identifying within one specialty of interest, such as behavioral health, those that are likely to benefit. And we can tailor those rules. As you can see, we don't do just PGX. We can also tailor to oncology departments by identifying patients that could benefit from additional testing. And this is done in this particular example, patients that have received tumor profiling where we suspect that there is a germline mutation. We have algorithms that can help oncologists identify these cohorts of patients. This pre-test candidate selection is done, as I've shown you in this previous slide, at a cohort level, but it's also done at a patient level at the point of care during the encounter. And as you can see, the lower screenshot here, which is a little bit blurry, is a screenshot of the Allscript EMR system. And we have embedded an analysis that scores this particular patient for their polypharmacy risk, focusing on PGX medications. So we can simply, by looking at the medications the patient is on, inform the physicians that whether a pharmacogenomic test is suitable or not. And as you can see, within the same window in the EMR system, a test order can be placed. So there is no need to go to a standalone application to place the order. And we do that on a per patient basis, and as I said earlier, as well as across an entire patient populations. This is a different view of a different EMR system. This is Cerner application. And as you can see, the PGX benefit or pre-test score can be done already in the provider view. This is a very typical view that Cerner users are familiar with. And we can embed the score or the alert by also listing simply the medications that have triggered that specific alert. Users can drill down if they would like to know more about the relevance or the issues the pharmacogenomic test can help them with. They can simply click on every medication and they will be getting more information, such as which gene is going to be relevant and will be tested by this multi-gene panel. My colleagues earlier mentioned that most of the testing in the United States is still done through this multi-gene panel. Not as a single panel. And this fits very well the scoring capability where multiple drugs can be analyzed in order to place the order. The next important pillar that allows us to actually bring pharmacogenomics into clinician is the availability of strong clinical evidence, but it requires still some level of data federation. I have the privilege to serve on multiple of these authoritative societies such as CPEC, as well as PharmVar and AMP. And as you can see, the roles of these entities are different. Some of them are important for us to focus on genes and variations, helping us identify which variants to look for when you are ready to test for specific pharmacogenes. But entities such as the Dutch Working Pharmacogenomic Group and CPEC are there to provide us with recommendations. We have built in our backhand for our To Be Precise platform a database that includes all recommendations from all of these entities. The next pillar that our platform needs to support is around the laboratory needs. And we provide support with our pharmacogenomics expertise in helping labs choose the relevant methodologies for a specific assay. For those that are familiar with the PGX, CYP2D6 is rather a very complex gene, and not all assays or commercial platforms are able to actually inform and provide you with the right diplotype that's clinically actionable. There is a variety of post-analytical tools that a lab needs to understand and enhance and integrate in order to translate those raw genetic results from the instruments into something that could be consumed by a clinical decision support. An example was alluded earlier into this haplotyping tools, and there are multiple haplotype softwares that are available with each limitation. So we integrate with at the level of the diplotype and haplotype, but sometimes we work with our laboratory partners to actually help with the translation of these into these haplotype or star alleles. For some genes, it's not a matter of translating them into haplotype, but it's a matter of providing an activity score, which is the input that is needed to actually trigger the clinical decision support. So the phenotype, sometimes, as you know, for some pharmacogene, is insufficient. So you need to integrate at a deeper level, and sometimes it's at the genotype level. And finally, labs are not they're not very, I would say, medication savvy. They were not built to actually receive and manage medication profiles. So we act and we do that for them in order to be able to generate that report. We also handle a lot of these operational workflows such as ordering, billing, reimbursement, etc. So you are all familiar with the result format that labs usually actually provide, which is this PDF. We can concatenate results from a PDF, whether they're diplotype, genotypes, activity score, phenotypes, and we can merge that with our back end, which has all these knowledge bases from CPIC, from the Dutch, or other parties, in order for us to recreate and assemble branded reports for our users or clients. But more importantly, these reports are usually presented to someone who is a non-genetic expert. So they usually have limited recommendations, and we try our best to shorten them, although, as we all know, we still suffer from the disease of 56 pages or so of the report. What is important is we recognize very early in our process and integration that the PDF is obsolete the minute it's printed, as one of our colleagues mentioned earlier. So what we do usually is we actually disassemble that report, and we get discrete results through different mechanisms, HL7, JSON file, you name it. We also have APIs where we can get the raw and structured data. And that is what actually is used as an input into our different engines. We use that to do multiple things, to derive clinical decision support and alerts. We do that to identify new insights, such as in oncology. And we do that sometimes to actually identify additional tests that could be ordered to complement the therapy management, especially in oncology. And finally, we also have a brand with oncologists when we use genetic insight to identify clinical trials for patients with specific genetics alterations. So this is a view of our integration in EPIC. So this is the EPIC EMR. We are already in the app orchard. And this view, as you can see, this is one specific patient. And for this particular patient, you can see that we can surface multiple layers of genomic insights. We have not only the drug-gene interactions that we have identified after the patient was tested, we also can see whether the patient has some signatures within somatic mutations because they have received a tumor profiling. For example, this is an example of a patient with colon cancer. And in some cases, as you can see, especially in oncology, a genetic counselor will then, at the time of diagnosis, will build a pedigree in order to identify, depending on the type of cancer and alteration, whether there are other family members that could benefit from testing. So this is really a federated view that can tell you a lot about the patient, not only from their pharmacogenomic liability, but also other types of genomic insights that they might have. This is done passively, as you can see. This is a different view, this time at the time of the encounter. This is for a specific patient. And as you can see, within the EPIC, we store the discrete results, so the genotype results of the pharmacogenomic signatures that were obtained. We have a pharmacogenomic profile that is on demand, And when the user clicks on it, it brings all the medications, focusing on the medications that the patient is on at the time of the encounter. And it, of course, it will surface those red, yellow, green alerts with this traffic light approach, and it will provide the corrective actions based on the CPEC recommendations or other sources of information. So this is done automatically. This data is updated constantly. And when new medications are actually added, the system is automatically refreshing, and there is no need for the user to input the medication because this is already in the record, and the minute the patient record is updated, the medication profiles are updated as well. The passive on-demand alerting is also deployed in a different manner in our Cerner and in the Cerner environment. So this is a different implementation for a different health system in Cerner. And as you can see, again, it's the same idea. We not only store the PDF, which is usually seen the first time the test is ordered, but we store the discrete data. This is an example of all the discrete data that was obtained from that multi-gene panel. And this data is then used as the input to actually populate these passive alerts on demand. There is a little widget in Cerner that reminds users that there is some interesting information to discover. These are not interruptive. Our experience with many users in the United States is they often start with passive alerting until their providers are comfortable enough with the pharmacogenomic information, and then they move into disruptive alerts, which is my next slide. So disruptive alerts are slightly different. This is a post-test disruptive alert that can be generated. Again, this is in an Epic and in a Cerner view. The advantage of the active interruptive alerts is we can dial them and we can actually filter them based on the customer needs and the drug gene pairs of interest. So for example, an oncology department is going to be focusing, for example, of creating disruptive alerts for 5-FU, but not necessarily alerts for other therapeutic medications. So our system was built to do that. Second advantage is active alerts allow us to actually collect the actions that the healthcare provider has taken once we provided that recommendation. Did they ignore the alert? Did they follow the alert? And this is what allows us to actually run our analytics in the background and inform the entire program after a couple of months. And that's what we will be using to fine-tune the alerts moving forward. We have experienced sometimes, for example, silencing certain alerts, not building more alerts, but actually decreasing the number of alerts based on customer needs. This is an example of the analytics that we can run. So this is just one example of One Health Systems where we worked with them in their elderly population. We stratified them, we identified a little bit, 19% of the population could benefit from a test. And when we deployed testing, we noted that within the patients with cardiovascular disorders, 40% actually where percent of medication triggered pharmacogenomic implications. So we worked then into plugging this into a cost-benefit analysis model, informing them of what are the returns on this program. So to finalize, as I mentioned earlier, because our platform integrates multiple types of genomic information, this is an example of a different type of report, which is a tumor profiling report from Foundation Medicine. This is Foundation 1 profile. And we integrate discrete data from the somatic alteration into this view. So this is for one specific patient. And once we identify the somatic alteration, we can then inform on the targeted therapies that this patient can benefit on But we can also do other things, such as identifying possibilities for additional testing. We have deployed algorithms where we look at the somatic alteration, and when we suspect that this is a germline mutation, we can identify these patients. This is extremely beneficial to our cancer centers, and this, as you can see, can trigger additional tests to be ordered. This ability to bring for oncology systems both somatic and germline genomic data allowed us to create this unique timeline. This is our signature product. It's called Precision Medicine Timeline. And what this is really a unified time-based view that takes all the patient data, clinical data, genomic data, radiology, different types of tests, different procedures. And it allows really the oncology team to not have to go into multiple places in the EMR to get the entire picture. This is done over time. You can see the medications, the anti-cancer medication that this particular patient had received. You can see on the top the different somatic alterations that were found. And you can drill down each time. The care team can drill down and observe. As you can see, we have added the pharmacogenomic component, the germline for anti-cancer patients, for anti-cancer medication, as well as all the supportive medicine that a cancer patient can typically take, which is opioids, antiemetics, et cetera, et cetera. So this particular view here is for oncology, but we are deploying this particular view to other specialties, for example, for rare disorders, such as for pediatrics, where often for diagnostic odyssey, an exome, for example, could be ordered, a mutation would be ordered that will establish what the condition of the child is. Later on, we can add the PGX component if therapies that are meaningful for this condition happen to be pharmacogenomically guided. So some takeaways based on our experience. We are well positioned, all of us, because we have these authoritative resources from CPIC and so forth, but there is still need for data federation to be able to take all these recommendations from multiple sources and make sense of them. There are multiple layers of bioinformatics that are needed from the lab side as well as from the recipient side, and all the other systems that are interested in getting genomic information, such as those pharmacy systems. The needs are different, and all, the platform can help us really take all these raw genetic outputs and give them and translate them into that clinical insights. To ensure broader adoption, we realized that really this empowering the users in that pre-test phase is key, and giving them the tools to quickly identify the recipients for the test is important. And of course, we really recognize that maybe active alerting is not necessarily for some constituent the best way to start, and that's why we have also built passive alerting modalities in our platform. So in order to go beyond a pilot implementation for PGX or for any other genetic domains, we recognize that there is a need for this universal digital central exchange, which we have built with our 2B Precise. And this allows us to serve multiple domains, including pharmacogenomics. Thank you.
Questions? So I may have missed it, so apologies if I have. So you've shown the genomics data. Are you taking into account people's renal function, hepatic function, and drug-drug interactions as part of that?
For PGX, not yet, but for the oncology, that's what we're on, is all of the other clinical variables, including diagnoses and scenarios. For PGX, there are also situations where for the alerts, to silence the alert, we need to know what's the indication, like the coding story.
Yeah.
Is it for cough? Is it for pain? So that's the next thing that we are working. And finally, no, we didn't speak about it, but this, how the drug-drug interaction can actually affect pharmacogenomic recommendations with the phenoconversion is what we are now deploying.
Okay, so that's for work in the future.
Absolutely.
And in terms of impact, from what you've done, you showed some data,
Yeah.
but have you actually shown the impact? Have you done a full impact analysis on how many adverse drug reactions have stopped? How many
It's a very good question. So we are working with some of our clients to actually gather some of these metrics. And as you can know, for example, with facilities, the outcomes that they're trying to collect is, for example, fall prevention. Is if I deploy this for this particular, am I going to reduce the fall? So it's really to identifying the metrics that we're gonna monitor in order for us to do that. We did some modeling. We have tools when we work with organizations to, the minute we do the stratification, where we have a cost model where we can predict the cost that is likely to be, for example, reduced if a program were to be deployed within a specific setting.
Okay, great. Okay, any other questions? If not, thank you very much.